I'm Jonathan Fritz, the Chief Innovation Officer at Chime. For those viewing live, we're excited to have you join us today. And those viewing on demand, welcome. A special thank you to our leading supporter, ClearSense. Let's start with why. Why are we launching this program? Most hospitals aren't set up to engage with nimble startup companies, and most startups don't know how to partner with hospitals. COVID-19 has changed that game. Now, hospital executives see what is possible and how quickly and effectively problems can be solved when you remove roadblocks. We want to remove the roadblocks for solutions positively impacting health and care globally. As a startup investor and recovering patent and venture capital attorney, I'm keenly aware of this problem. Simply put, we want to highlight innovation between health systems and startups. This program is all about real problems faced by hospital leaders and how they solve them in partnership with emerging technology companies. Today, we're focusing on the partnerships between Sheba Medical Center and Datos to address remote care. Thank you to our speakers, Dr. Eyal Zimlichman, Deputy Director, Chief Medical Officer, and Chief Innovation Officer at Sheba Medical Center, and Uri Bettesh, Founder and CEO of Datos. Time permitting, we'll take a couple of questions at the end, so please submit any questions in the Q&A tab. Chime members are welcome to join a special behind-the-scenes session immediately following this webinar. At the end, please exit this webinar and join the separate Zoom meeting. I'd like to thank Darren Dworkin, CIO of Cedars-Sinai, who will be our moderator for that. Darren is one of our Chime board members, and special thank you for waking up early on the West Coast. Also, this session is being recorded, will be available for on-demand viewing. With that said, I'm going to hand it over to our leading supporter, ClearSense. Philip Furukawa, the Director of Sales at ClearSense. Philip, take it away.
Good morning, everyone. Thank you for joining us today for what I'm sure to be an intriguing discussion, highlighting how Datos Health and Sheba Medical Center's partnership to deploy Datos' automated remote care platform to support Sheba telemedicine program in preparation of COVID arriving in Israel. My name is Philip Furukawa. I'm the Director of Sales here at ClearSense, where we provide a holistic data platform as a service that enables providers to achieve their data maturity goals. We're honored to be sponsoring today's speakers, Yuri Bettesh and Dr. Eyal Zimlichman. Mr. Yuri Bettesh brings with him 18 years of experience as a technology executive and a passionate entrepreneur with a proven track record of success in leading business operations and technology implementations. Yuri is a visionary leader with the ability to initiate and execute innovative strategies, engage in highly professional management teams, and lead to results in fast-changing business environments. Dr. Eyal Zimlichman serves as Deputy Director General, Chief Medical Officer, and Chief Innovation and Commercialization Officer at Sheba Medical Center. Previously, he held the position of Lead Researcher at Partners Healthcare Clinical Affairs Department in Boston and was heavily involved in the efforts to implement a strategy care redesign initiative there. Dr. Zimlichman has served on several advisory committees commissioned by the Offices of National Coordinator for Health and Information Technology at the U.S. Department of Health and Human Services and is chairing as well as participating in several committees as Israel's Ministry of Health. Dr. Zimlichman is the founder and director of Sheba's ARC Innovation Program, an open global innovation ecosystem which aims to redesign healthcare through digital health solutions by 2030. He is a board-certified internal medicine, completed a degree at Hartford T.H. Chan School of Public Health, and earned his MD at the Technion Israel Institute of Technology. Without further delay, I'll hand this off to Yuri and Dr. Zimlichman.
Thank you, Philip. I think I'll start our presentation. Let me just share our slides. Great. So I hope you can all see the slides right now. What we thought about doing is sharing our experience, which of course is going to center around what happened with COVID-19 in the past few months, which is what we're all speaking about these days, and the need for a comprehensive telemedicine platform at Sheba Medical Center, which actually the journey specifically with Datos started just before COVID-19 and actually brought us ready towards the challenges that COVID has brought with it. Of course, I'll start with saying a few words about Sheba Medical Center. For those of you not familiar, Sheba is the largest health medical center in Israel, also largest in the Middle East. It has about 2,000 beds, all on one campus that you can see here in this aerial photo. Comprehensive care that includes both an acute care hospital, rehabilitation, a children's hospital, a women's hospital, and a cancer hospital. Again, all on one campus with very strong roots in research and innovation in the past years. Sheba was also voted as the #9 hospital in the world by the Newsweek ranking that was just published this past March. We're very proud of this achievement, of course. And when we talk about the trends in healthcare, of course, many of them can be spoken about, but specifically what I want to share with you is the understanding we have that care is going to shift out of hospitals. We see this as two main reasons for that. First of all, we know that care in the hospital is expensive, and second, that care at the hospital is unsafe. We know that, and care will be pushed out of hospitals to the home. We see this already happening in the US, but very slowly from 1950 to today. Inpatient days per 1,000 population going down from about 900 to 630. And we think this will be accelerated in the next few years, and COVID is going to further accelerate that. Digital health innovation specifically will play a critical role in enabling that to happen, whether it's precision medicine and telemedicine and others. Our ability to predict and prevent and then cure and if nothing else works, rehab will push patients outside from hospitals. And hospitals will get smaller with fewer real beds and more virtual beds. Again, something that we're starting to see in the past few years. With hospitals typically focusing on intensive care, complex surgery, and specialized services. The future ecosystem, the hospitals will need to be a hub within an ecosystem or an academic health system delivering integrated care. Care will shift outside of the hospitals, and technology will enable the breaking of geographical barriers, as we're about to show you. Hospitals will become smaller with fewer real beds, as mentioned, and more virtual beds. And finally, there would be a need for untraditional partnerships, internet companies, telco companies, education, and welfare, as we try to take responsibility over populations across the continuum of care, well before the patients become sick, trying to prevent disease. What is the innovation that will enable this type of transformation? We're seeing this in a couple of in levels. They're all centering around digital health. We're going to talk mostly about telehealth, but of course, artificial intelligence is going to play a critical role here as well, and virtual reality and augmented reality, and also robotics, not just surgical robots, but also other robots inside the healthcare system are going to play a growing role in the next 10 years. So there's going to be need for a lot of innovation to make this transformation happen. And this is why at Sheba, we started and launched about a year ago, but actually we're working on this for about 4 years. We've launched the ARC innovation ecosystem. ARC stands for Accelerate, Redesign, and Collaborate. Accelerate innovation to redesign healthcare by collaborating with partners. And it's really about this ecosystem that shares the common vision of how healthcare needs to look like in the future, and then working proactively to make that vision a reality. Within ARC, we're focusing on these areas, of course, in digital health. We call them hubs, the ARC hubs, from big data and artificial intelligence to virtualization of medicine, VR and AR and 3D printing as well, to the operating room of the future, telemedicine, of course, rehabilitation, and personalized medicine. We're going to focus on telemedicine on this talk, but really just to show you the broad perspective. Now, the building blocks for transformation as we see them in telemedicine are looking at these 3 areas, from acute care to chronic disease management and to rehabilitation. And these are the projects and programs that we have running at Sheba and that we were looking for solutions to. One, the hospital at home program, both for medicine and psychiatric patients. That was something that we saw as a strategic change in us pushing care towards the home, but having the hospital play a central role in that. And of course, that demands that we have the technology and the innovation platforms to allow that to happen. And we'll talk more about this as we talk about Datos and what they bring to the table. On chronic disease management, we've been doing a lot of work with virtual diabetes type 1 clinics, but also we've developed a very unique program for chronic disease management we call it MICA, Managed Integrated Continuous Care Applications, which basically can be applied to almost any chronic disease that you can think about, from diabetes to heart failure to Parkinson and epilepsy and dementia and many other areas that we can have this focused around. And specifically for rehabilitation, we've been doing a lot of work in the past almost 10 years with telerehabilitation, but we started becoming much more focused. For example, building a program for telecardiac rehabilitation, and Datos, of course, played a critical role in this as well. Overarching, we've been putting a big emphasis on patient-reported outcomes and specifically symptom management for patients, whether it's acute, chronic, or rehab. We have more than 40 different programs for PROs and symptom management at Sheba, from orthopedics to oncology to gastroenterology and so on, psychiatry and almost any area that you can think about. And we had a system already working before Datos came into play here. But of course, we were lacking a lot of the major elements that a good PRO program needs. And Datos was meant to bridge the gap to where we need to be in the future. And so this is sort of the full perspective of what we wanted to achieve, looking at what we're launching in right now and in the next few years. So how do you choose the right partner? We actually went through a tender and an RFP to find the right vendor to get us to join us in this journey that we're about to take, transitioning from what we've been doing before, a lot of activities already happening, but really bringing this to the next level. We had multiple companies, I think something like 12 companies that approached and submitted to the RFP, from small companies to large companies, really the whole spectrum. And we were looking for a couple of things. One is the mutual vision. How do we make sure we share the mutual vision with our partners? Because we saw this as a partnership, much more than just a vendor versus client relationship. Agility was critical because the wide spectrum and the comprehensive system-wide solution we were looking for, our ability to be agile and work and come up with new solutions all the time was critical. And of course, understanding how to integrate into workflows. And anybody who's working on a clinical platform knows that this is really critical. And finally, past experience, trying to learn from our past experience, integrate that into future solutions. That was critical for us, again, because Sheba Medical Center made a huge, this was a huge journey for Sheba for many years now. We've been completely digital for about 15, 16 years already, with EMRs integrated into Sheba, at the end of the 1990s. So for us, drawing for past experience was critical. So I think from here, I'll turn it over to Uri and come back to finalize our lessons learned at the end. Uri.
Thank you, Eyal. Can you hear me okay, by the way?
Yes.
Okay. So I think what I would like to do is I would like to share with you the key attributes of how we built the Datos platform, and what are the key attributes or the key points to consider when we develop that platform to an organization in the size of Sheba. One of the first thing is that we didn't invent the remote care. As Eyal said, remote care was all along, but the reason it was not widely spread, the way that we think about it, is because you didn't have a platform that it is easy to deploy in a cost-effective manner. Meaning that for every program within the hospital around the remote care, we do have some kind of a sponsor. Either it's going to be a CPT codes or it's going to be a research, but it has to be tied into economics. And what was important for us is to have the ability to rapidly deploy different remote care programs in a very easy and a cost-effective manner. Now, when you do that, our approach is not to take only the patient side or the clinician side or just the device integration side or just the video component, the virtual visit component. There are a lot of different modules inside the remote care umbrella, if you will. And our approach is that everything has to coexist together into one experience. And when we say user experience, we mean both the clinicians and the patients. So video on its own, it's not enough. It has to be video, but it also has to be something that ties to patient journey, integration to devices, EPROs and PROMs, patient-reported outcomes. All of them are activities that are being done remotely, but and has to encompasses the same user experience in between them. Then we looked at the different type of remote care within the hospital, and we look at 4 different types, where the 2 types, real time versus asynchronous. Some people call it store and forward, meaning that there are departments or clinics within the hospitals that would like to monitor the patients in real time. That's usually the case in home hospitalization. And there are other departments that would like to monitor patients or to provide remote care in an asynchronous manner, like in oncology, for example, in symptom management and such. And then there is another question, whether that remote care operation would be part of the existing workflow, or whether it's going to be a dedicated operation. Usually real-time will be a dedicated operation, but we still see more and more hospitals integrate home hospitalizations as part of their daily routines. How we can, make sure that we are in the right cost effectiveness or in the right budget and not imposing more work on the clinical staff, it's all around automation and the ability to take existing workflows and to automate them into the system, and to allow the right stakeholders to be notified and alerted at the right time, and only when needed. And when not, we can let the system run automatically and interact with the patients in an automated way. In my mind, that's the whole key of around remote care. And anything that is not supporting automation will not be managed to scale to the right, manage to scale. And last but not least, what we also find out is that user experience, as I mentioned before, is important not only from a patient perspective, but also from the clinician side. When a nurse that I met inside in the hospital would ping me and send me a message and alert as a patient, I would be much more engaged to the program. So it is important to take 2 sides of those equations. It's not only the patients, it's also the clinicians, and we have to look at them from a user experience perspective, not only clinical process. Can I move another slide, or Eyal? Thank you. So the Datos platform encompasses from 4 main components. One is the devices, agnostic integration to devices and the ability to manage them agnostically. So in the remote cardiac rehab that Eyal mentioned, we're using non-FDA devices. However, in home hospitalizations, we do use FDA devices. And the ability to mix in between and to use the right device for the right use case is really important. The mobile is the mobile platform. So every department within Sheba, they have their own mobile app. Some of them would like to use a full day-to-day companion app. Others would like to use the app or for the virtual visits only, or for the PROMs, the EPROs only. And every department can design their own user experience as a patient. And that goes as well also for the clinical workflows. Every department can design their own designated workflow and how they would like to integrate that data into the day-to-day clinical journey. So there is a lot of emphasis around automation, around data engines, and around how we cleanse the data, manage the data, validate the data, and tag in terms of context tagging the data itself. Eyal, can I move to the next slide, please? Thank you. And when we talk about automation, it's all around how we build those decision trees and how they manifest themselves into the mobile app. This is an example of a CRS side effect in oncology. The ability of Sheba to build those decision trees without any IT help and without our help. They were completely independent to do that on their own. And that's the magic, because that has to be all the time dynamic. Requirements change all the with time, and the ability to provide agility in the protocol building, and basically to provide a studio for Sheba to build those remote care plans on their own. In our mind, that's a key for rapid implementation. Next slide, please. And then we go into the examples. So today in Sheba, under the same platform, I think it's a year since the tender that Eyal mentioned. We are running a remote cardiac rehab program that actually just the Ministry of Health issued a new reimbursement code based on that program. A CHF early discharge of CHF patients, psychiatry home hospitalization, something that is very close to Eyal and I is the PROMS and the EPRO initiatives, where we work on different channels, so like in-app text, IVRs, how we integrate the dashboarding into the EMRs and the clinical workflows. Breast cancer and symptom management, it's only a tip of the iceberg. That's going to be widely spread across many other oncology departments within Sheba. Another example of research, which is in a day, we onboard a pancreas cancer research. And of course, the virtual clinics. There are many clinics within the hospitals that are using Datos only for virtual care. Scheduling, waiting rooms, group calls. And what is nice about the solution is that the fact that as a patient, you don't need to download an app, you don't need to go through a lengthy registration process. On the time of the visit, you're just getting a text message with a link, pressing that link, and you are in the virtual visit room. And of course, there are other departments. Just before we, can you go back? There are other departments that are in line for going live. Bariatric clinics or head and neck cancer, IBD, diabetes, as Eyal mentioned. Some of them are ready to go with no enhancements whatsoever. Other require some integration or some enhancements like device integration and so forth. The idea is to cover as many departments as possible with one unified system that allows Sheba with a remote care studio to design their own remote care programs. Please go ahead, Eyal. That's another view of the system. As I mentioned before, integration to devices, virtual visits, and a very, very nice and personalized dashboards and workflows for the care teams. A little bit about Datos. So yeah, if you can move to the next slide. We were founded in 2015. We have 40 employees. We raised so far $10 million, and you can see some of our clients in the slides. We work pretty much across the Israeli healthcare system, which is very easy for us because Israel is very advanced from a health IT perspective. As Eyal mentioned, we have EMR implementations from basically 2000. So the hospitals here and the health organizations are ready to deploy new IT platforms. And in the States, we're focusing on tier 1 accounts, and we also work with partners like Strategic Interests that introduce us to Rochester Regional Health and other major accounts. Eyal, if you can go to the next slide, I think that you will take it over from here.
Yes, thank you, Uri. Looking at the past year, from pre-COVID to post-COVID, or at least as we're still in COVID right now, some of the challenges that we saw, from both perspectives, the Sheba and Datos. One is, of course, the bandwidth, and we saw that on almost every level. The amount of activity that happened in the past few months in the telemedicine space was huge. Whether it's internally here inside the hospital, where our own IT teams and innovation teams were fully deployed to try and support bringing in as many clinicians as possible and as many services as possible into the program, into the telemedicine program was a huge challenge. And of course, for Datos as well, as they started having more and more clients people jumping on board right now, trying to get more and more IT solutions for telemedicine, bandwidth is a challenge that we're going to have to manage on every level, from our own level, on Datos level, and so on. Rapid development and deployment of technology, as mentioned, as we are moving very quickly. Obviously, we're moving and then we're correcting as we move along. We don't have always the time that we probably would want to take as we launch new services on tele and so on. So that's been a challenge. Of course, user buy-in and resistance to change, as you know, is always an issue when it comes to digital health and telemedicine specifically. How do you get the doctors on board? That was always a challenge, and I think obviously COVID has also opened a couple of opportunities in that as well. I'll mention that in a second. And then integrating into existing systems and workflows. At Sheba, we have so many different IT systems. Some have been built 20 years ago. Some have come in the past 5 years. So how do you integrate into existing systems? And of course, workflows is always a challenge. Opportunities, COVID-19 is an opportunity. As we all understand, I think everybody on this webinar right now understands that, and we're trying to take full advantage of that and push ahead as quickly as possible, taking advantage of the need for change. Leadership buy-in, that was an opportunity as well. At Sheba, telemedicine is really a strategic focus. We've put this as a strategic focus to becoming virtual on many accounts before COVID-19. Of course, COVID-19 again pushed that agenda forward even further. So when it comes to leadership buy-in at Sheba for this, it was a huge opportunity for us to push ahead. Regulatory support. We're starting to see things here in Israel and also in the States and other countries that have not been around before COVID in terms of the regulations that allow us now to expand telemedicine further. In Israel now, all the insurance companies and the HMOs have to provide reimbursement for telemedicine. So that from our perspective, that's a huge opportunity. And potential for substantial improvement in efficiency and cost savings. As you understand, as we push to telemedicine, there's all this potential cost savings and efficiency that we're starting to realize right now and starting to measure right now. And that would be something that, again, would help us push this forward even further. Uri, some of your takeaways.
Yeah. I just would like to add also on the challenges slide, and you mentioned the integration. I cannot emphasize enough how important it is to have the ability to do that in parallel, meaning not to hold innovation by the integration. Integration is always to the EMR and to other systems. It's always a hassle, and it will always take time. There's no magic. There's no magic to it. But having the ability to work in parallel and support innovation, and at the same time to support the integration is really crucial. And from our experience on the opportunity side, first, gaining an experience to work with one of the leading hospitals as Sheba is crucial for a company like Datos. Especially when we talk about multiply projects and not only one vertical, but to cover such a broad bandwidth inside the hospital when it comes to remote care. And there is a true collaboration and partnerships also with the roadmap design and with commercializations of new modules. So that's a great honor to work with hospital as Sheba.
Well, Eyal and Uri, thank you very much for the the presentation today. Really appreciate it. I can attest to Sheba's advanced innovation initiatives, having visited with them last summer and seen their campus. Eyal was a tremendous host. With that being said, I wanted to thank ClearSense again, our supporter for Innocast. We're now going to transition to a Chime members only Q&A session. So all the Chime members that had signed up for that, please navigate to the separate Zoom meeting, and we'll kick that off here very shortly. And one final note, coming up on August 25th, we'll have an Innovation Beyond the Edge program with Ryan Smith, the new CIO at Intermountain Healthcare. And September 10th, we're going to have another Innocast program with Dr. Daniel Nygren, as well as John Brownstein at Boston Children's Hospital. So thank you everyone for joining us, and we'll see all the Chime members here shortly.